In this section, we're going to talk about the axial skeleton, kinematics, and kinetics. We're going to talk about it in general terms throughout the whole vertebral column, and then in the next couple sections, we'll get into the breakdown of the lumbar spine, thoracic spine, cervical spine. Let's just remember that we are lucky to have that intervertebral disc that allows more motion to happen, especially in relationship to tilt. If we didn't have that intervertebral disc, we would only be able to have translatory motion occur. And so as we move forward, we're going to talk a lot about tilt and gliding, and then we'll also talk about rotation as we get into our discussion. So in the spine, we need to understand that there is a coupling of motions that occur, that really true lateral flexion and true rotation don't occur independently of one another, and that these are often coupled with one another. Studies have shown that it is greatly varied amongst individuals as well as locations throughout the spine of what that coupling action happens. We used to think that lateral side bend and rotation always occurred in the same direction, but that's also very depending on the person and if there's actually pathology within that. We'll talk in the section of our lumbosacral section of Fryette's laws, and we'll come to understand that. Just I want to always implore with you guys that it's going to be varied, and that you might see something different even amongst your patients and your lab partners. So although these are guidelines, it's not always necessarily true. The size of the disc is really important in our kinematics, and this is how much motion can occur is based on the size of the disc. And our facet joint orientation is the way or the direction in which the motion will occur. The tilting and gliding of that superior vertebrae, so I always make my hands into two fists and put one on top of the other, and that will help us as we talk through what's happening. And so our top hand will be the superior vertebrae, our bottom hand will be the inferior vertebrae. And as our superior vertebrae moves through a range, it follows a series of arcs. And at those different series of arcs, it has a different instantaneous axis. So just understanding as we move through that, if we picture our graph, we have instantaneous axes occurring around those. Let's talk a little bit about what happens in flexion and extension. So if we put our two hands together and we go through flexion, we're going to understand that we have tilting and gliding, anterior tilting and gliding of that superior vertebrae over the inferior vertebrae. We just talked about those different arcs that it goes through and those different axes. But let's think about a little bit, especially in this picture, we can see that as that superior vertebrae is coming forward, we're getting separation into from the spinous processes. So if we just take a look, let's pick a different color today. If we take a look between these two spinous processes, there's separation happening. We'll also understand that vertebral foramen is opening or expanding. It's not narrowing. So as we will see with extension, that vertebral opening is narrowing. So we always want to think about what's checking that flexion, meaning what's stopping that motion. We know that it's the supraspinous ligament, so that's that blue line I just drew, and then we have the intraspinous ligaments, so between the other areas as well. We also get a lot of tension from other areas, so think about that PLL. We talked about that in the earlier section, and then the zygapophyseal joint capsule is going to provide some tension, and then that ligamentum flavum is also going to do that as well. As we go through, we're getting anterior compression of the annulus fibrosus, and we're going to think about that. We're going to have some compression into the area anterior. So, and that will be the opposite when we think about extension. It will just change and move opposite. So as we look at extension, we see that these spinous processes are coming closer together, and you can see that's varied as we move down into that cervical spine. How much is happening? Does this person have maybe a forward head posture where C1 and C2 are shifted forward? But that superior vertebrae is tilting and gliding over posteriorly over the inferior vertebrae. So if you guys go through that with your hands, that flexion and extension with your hands. The intervertebral foramen narrows, and as we go through that, which is important for us just to understand as we talk about our patients and understand that's going on. So what's checking our extension? As we can see, these spinous processes become closer together. Our zygopophyseal joints actually come closer together. So we just want to make sure that as we start to understand, if someone is complaining of a sharp pinch, maybe possibly in their neck, maybe that lateral side of their neck, it might be because there's not enough space between that zygopophyseal joint or those facet joints. So what checks our extension? The joint capsule will also check our extension, but really that anterior ALL ligament is what is checking our extension. And if we think about all the things that check flexion versus all the things that check extension, that ALL is much, much thicker than the PLL. And it makes sense because that's really the only ligament that is checking that extension. So we just always come back to considering our nature with that. Okay, let's move on and talk about lateral flexion. And this we'll talk about quite a bit as we get into our different segments, but understanding that so if we do our two hands again, our superior vertebrae laterally tilts, rotates, and translates over that adjacent vertebrae. The foramen, and we can see that on our picture here, will expand into the convexity side. So we'll have opening here, and then we'll have closing down on the concavity side. This is also true of the facet joints. We're getting closing down as we move through our motion, and then we're also getting opening on the opposite side. The rotation that accompanies lateral flexion is very region dependent, and we'll dive into that later into each section more in detail. And in some sections, we're going to have a significant amount of rotation, but then in other areas like the lumbar spine, we shouldn't have a significant amount of rotation, and the orientation of the facet joints will match that. We can also just appreciate that as when we move into kinetics, talking about compression, that as we laterally flex, we're increasing compression onto this side. And so, again, if we think about what's happening as far as a patient complaint goes, is we need sliding and gliding to occur at each of those facet joints, and so that they're not getting stuck in and on each other. Just a way in which we might improve that would be a mobilization or a mobilization with movement. And so we start to apply what we're doing in our practice setting and in our lab setting. Okay, so let's just touch on Connect. So this is just a kind of a pop quiz for you guys. If you can name the 5 forces that the vertebral column is subject to. So just think about, even as you're sitting there watching this lovely recorded lecture, is what forces are acting on your vertebral column right now. What happens if you rotate or if you reach down? What happens as you're just sitting for a long period of time? What about if you reach to the side? So think about all of those forces that are acting onto that. And now let's dive in a little bit deeper into some of those. So axial compression is one of those main areas that we are always concerned about as physical therapists. And it's a lot to take into consideration, right? It's the force of gravity. Sometimes when you guys are going through learning your manual muscle testing, we're going to do gravity eliminated positions, which you can never eliminate gravity, but it's a way in which we can position the body that maybe it is not always trying to accompany for gravity. And then ground reaction force, so what's happening as we hit the ground. So as our foot's contacting the ground, or if we're kneeling, our knee, if we're in, like a plank or a push-up, our hands. So remember, ground reaction force is our contact with the ground. And then the forces of the ligaments and the muscle contractions. So lots of compression happening throughout that. I like this picture because it just helps us bring back into our forces and our vectors, and understanding that we have a lot to think about in relationship to the vertebral column and the forces acting on our body. So let's talk a little bit about loving our strong bones and our strong discs. That axial compression really is taken up significantly by our intervertebral disc and that nucleus propulsive. And most of our resistance is actually provided by the disc in that strong vertebral body. We get some of the force taken up through that neural arch and the zygapophyseal joints, although that's minimal, not a very strong percentage of that. Unless we're having, creep happen or there's an alteration in posture, then that will shift. And when that shifts, we start to understand that there is now a malalignment or maladaptation, and we're shifting compression into areas that maybe are weaker and shouldn't happen. So let's just consider, why do we need weight training after age of 40? If our vertebral column under the age of 40 is strong and elastic, what happens after the age of 40? And understanding that cortical bone carries a greater portion of the load after age of 40, secondary to the trabecular bone decreasing in strength and stiffness. And so we really want to make sure that as we're considering our patients coming in, we take a look at their age. We want to know what they're doing. I had a student one time ask me, well, Dr. Everon, should everyone be doing some type of strength training? And absolutely. In this day and age, with how much our society has moved towards computers and sitting and work that way, we really need to focus on making sure that we're getting that healthy tension into the system, and so that our bones stay strong, that we maintain that elastic recoil of our connective tissue as well. Let's talk about that lovely nucleus propulsive. So that fluid-filled disc, and then, it's circled into that annulus fibrosus. And it's such a great way our body has built a system. And that interaction between the nucleus propulsus and the annulus fibrosus is that as we have compression through the vertebral column in that upright position, that if you think about, okay, yeah, we have that little bit of that jelly donut, it's a thicker type of substance, so it's not just water. But as we push down onto the vertebral column, that will expand into that annulus fibrosus. But what's so cool about our body is that an equilibrium is achieved, meaning that there's a give and take of that pressure, and we need that pressure to help accept the load of that axial compression. This is the strongest area and will be actually the last to fail, just due to how the nature of the components and the makeup of it. And that if you think about other areas that maybe are not made to take all that axial compression, like the end plates or the zygapophyseal joints or that pars articularis, those might be more subject to injury and failure, especially with maybe overuse or some poor areas in that way. So why do we think that now we can apply that principle of creep? So as we move throughout our day, I don't know how many of you know that we actually shrink throughout our day. So you're much taller in the morning. So my husband played basketball in college, and basketball players are notorious for making their height a little bit more than it really is. I think Steve Nash definitely added a couple inches to his. I remember going to a Suns game and seeing his height, and that was definitely not his actual height in real life, but maybe everyone got measured in the morning. And they've done quite a few studies. Kapanji and his colleagues looked at how much disc height do we lose throughout the day, and it can be over a 0.5 millimeter that we lose throughout the day, and then it's interesting, they also looked at running, and they actually showed just with an hour of running that you can lose even more of that height, just secondary to creep happening. So what's our implications as far as a physical therapist goes as we consider load and the time on our disc? So if creep's happening, meaning that we're getting expression of water out of our disc into the end plates, how are we going to treat our patient? Does it matter what time of day we treat them? Are we looking at hydration? Are we looking at, are they in static positions all day? How do we help our patients so that we're really maintaining a healthy disc, but we're also maintaining healthy loads onto that? Okay, let's talk about bending. A lot of our activities are, what do you guys think, forward flexion or extension? Probably more in that forward flexion. We know that bending is a combination of compression and tension, so we're getting a lot of different forces into that area. And if you think about bending, if we think about what happens, so if we flex forward, now we're applying our thought processes as far as what happens to the ligaments, what's happening as we bend forward to our connective tissue in the back, what's happening in the front, what are we compressing on? So I want you guys to process through that, refer back to your notes, and really just be able to have a discussion around that. But then also, let's think about what happens when we bend to the side. If we functionally bend to the side, are we able to accommodate for that compression that's happening? And then are we able to handle the rotation that happens with bending to the side? Or are we seeing in cases like scoliosis that there is a lateral bend to the spine, and so now we're shifting, and what elements are being compressed and what's being tensioned, and then in relationship to that, what's happening to our muscles? We can gain a really good understanding that this can be a really hard thing to overcome as a physical therapist, because we need to make sure that we're looking at how the body moves in all three planes, really. And so that's a big take-home message with this. Torsion occurs around that axial rotation during our coupled movements. So we talked about that bending is compression and tension, and so now we can understand that we add torsion into that. With torsion, half of that annulus fibrosus, the fibers resist torsion clockwise, and the other half resist torsion counterclockwise. Again, if you look at an anatomy and you look at how the annulus fibrosus is orientated, it's just such a really great setup to handle extreme loads. And we're still trying to gain understanding of how much load, how much torsion, how much shear can our bodies really take. So you guys, and when you get into practice, or if you're already in some kind of practice, or you're starting to really look at the people around you, you'll often hear of a complaint of lower extremity radiating pain, and their mechanism of injury is that they bent forward and to the side, and they've either felt a pop, or they felt sharp pain, or they have now radiating pain down into their leg. So I want you guys just to kind of process through, if I bend forward and to the side, what's happening at the nucleus propulsus? What's happening to the annulus fibrosus? Are we getting compression on that concavity side? And are we getting tension into the convexity side? And then really, what's happening at that disc? Why are we not able to handle that? And what I want you guys to start to get to is that if we have maybe an EVS worker, and that's part of their daily job is bending forward, turning, and moving quickly through that, but then they go home and they never get stronger, and they never train into maybe a better posture or extension, or they're not doing strength training, their body isn't ready for that. And sometimes it's that we're building a fire, we're putting all these logs onto the fire, and that one time that they bend and rotate, maybe the load was just a little bit too much, and now we have compromise of the tissue and the disc, and maybe even those facet joints. So just continue to put yourselves in that position of a PT, thinking about those mechanics and all those forces that relate to that. Okay, so let's lastly talk about shear. Shear is those forces acting at a 90 degrees to the compressive forces above that. So occurs in both lateral and anterior and posterior directions. It was really great. Knapp and Maras in 2009 looked at the shear forces when someone is bending forward, and they also looked at occupational tests, so just what we just talked about, pushing and pulling. And what they started to see is that the zygapophyseal joints and the neural arch started to undergo creep, and that they began to take more of the forces over time rather than the intervertebral disc and the vertebral body. And we can understand this now as a physical therapy minded, that this is not good because those structures are weaker and they're not really made to do that. And so we start to maybe see some degradation of the actual bone. We see some dehydration happening and some fibrosis happening in those connective tissues. And so again, as you think about someone going through functional movements, think about, okay, what's happening as far as axial compression, what's happening with tension and torsion and bending, and now let's just think about shear. What is happening with that? And we'll talk a lot more about that as we move into the lumbar spine, is what's happening with that shear of our structures in and of themselves. Okay, great job. Good job listening. Okay, this is just what's happening next. Next, we'll go over more specifics in different areas of the spine. We'll begin joint mobilizations of the spine. What's your job is to practice, practice, practice. Make sure you're using your resources. Make sure you're still practicing your joint mobilizations of the extremities and as we move into the spine, and really trying to get a good hand feeling of what's happening with the body underneath your hands. Great job, and stay tuned for the next upcoming section.